Welcome to AETCM, the Emergency Medicine channel. Today we are going to discuss about weaning. The ability to breathe spontaneously is a criteria to determine whether the patient can be successfully weaned from ventilator or not. So we can tell that the patient has been will be able to wean successfully if the patient is able to maintain a spontaneous breathing for a particular period of time, and weaning failure is considered when this patient is not able to return back from mechanical ventilation, or if the patient is not able to sustain spontaneous breathing for a particular period of time. So, weaning success is defined as absence of ventilator support for 48 hours following an extubation. And absence of ventilator support means there shouldn't be any NIV support or any oxygen support or any need for bronchodilators or a positive pressure ventilation. And weaning in progress means patient in whom we have weaned or extubated, and then we have put them on face mask or any NIV or any nasal prongs, and the patient is getting better. So NIV plays a very important role in helping the patient to wean. And weaning failure means patient has failed the spontaneous breathing trial, or if without spontaneous breathing trial, if we directly plan on extubating the patient, and if the patient after extubation is in respiratory distress and this patient needs to be re-intubated within the next 48 hours, that is called as weaning failure. And the signs of weaning failure, if at all we are attempting to put this patient on a spontaneous mode or post-extubation, if the patient is tachypneic, if the patient is having respiratory distress, tachycardia, hypertension or hypotension, hypoxia, worsening of respiratory acidosis or some arrhythmia, these all are the signs of weaning failure. And other signs include patient might be showing some agitation, distress, reduced mental status because of type 2 respiratory failure, sweating, and increased work of breathing. So what all should be the patient condition prior to weaning? So make sure that the patient has been recovered from the indication for intubation. That means the acute phase of the disease should be relieved. That means patient should be out of that acute condition of disease. And the second criteria is the other conditions that can hinder the work of breathing of the patient should not be there, like a ventilator associated pneumonia or any other metabolic conditions. That all should not be there while we are planning for weaning. So the conditions which can hinder with the success of weaning is patient conditions like fever, infection, renal failure, sepsis, sleep deprivation, or any cardiac or circulatory problems like arrhythmias, low BP, high blood pressure, reduced or high cardiac output state, fluid imbalances, anemia, or any dysfunctional hemoglobins. We also should make sure that the patient doesn't have any electrolyte abnormalities or acid-base abnormalities, and patient should get adequate nutrition. So if the patient is having inadequate nutrition or some electrolyte or acid-base abnormalities, this can also affect weaning. So the 4 weaning criteria we will take into account for some parameters like our partial pressure of carbon dioxide. So PaCO2 should be less than 50 millimeters of mercury in a non-COPD patients. We all know that COPD patients will be having a high carbon dioxide. So in non-COPD patients, the carbon dioxide level should be less than 50 millimeters of mercury. The patient's pH should be normal. Patient should have a vital capacity more than 10 ml per kg so that we can extubate the patient, and patient will not be having much weaning failure problems. Then patient's spontaneous tidal volume should be more than 5 ml per kg, and the patient's respiratory rate should be less than 35 per minute, and the patient's frequency, respiratory rate by tidal volume ratio, or the the rapid spontaneous breathing index should be less than 100, and the patient's minute ventilation should be less than 10 liters with a satisfactory ABG. Minute ventilation, we all know it is a we multiply the respiratory rate and tidal volume. So that should be less than 10. If it is more than 10, that means patient is tachypneic. So we should check whether the patient is meeting this weaning criteria before extubating the patient, and then only we will be planning on extubating these patients. So we will explain these things in detail. So oxygenation. So this patient the patient which we are planning to extubate should have a PaO2 of greater than 60 millimeters of mercury on 40% FiO2 or less. So the patient should maintain adequate oxygenation without much FiO2. Then only we can plan on extubating. And the PaO2 by FiO2 ratio should be more than 150. That means the FiO2 requirement should be very much less. Coming to pulmonary reserve, we already told that the patient requires a vital capacity of more than 10 ml per kg so that this patient will be able to breathe normally after extubation. So what is vital capacity? Vital capacity is the inspiratory reserve volume with the tidal volume plus the expiratory reserve volume. So how will we check that vital capacity? So we basically want a spirometer, and patient should be instructed to breathe deeply and then exhale out deeply. So we will be getting the inspiratory reserve volume, the tidal volume with the expiratory reserve volume. And for weaning success, the vital capacity should be more than 10 ml per kg. Then we will be checking the patient's maximum inspiratory pressure. That means that how much negative pressure that patient can build himself so that this patient can inspire properly. So maximum inspiratory pressure is a negative inspiratory force that patient can generate for at least 20 seconds in an occluded device. So we want a measuring device that will occlude the airflow so that the patient can generate a negative force to suck in the air. So if that comes as at least minus 30 centimeters of water, then that means that this patient is able to create a negative force to inspire, and this patient can be weaned. Next is a rapid shallow breathing index. So as I told before, it is a ratio between the respiratory rate and the tidal volume. And if it becomes more than 100, that means that the respiratory rate is very much high, which means that this patient is tachypneic and this patient might be in respiratory distress. So if that is coming more than 100, that means this patient is having high risk for weaning failure. And if it is coming less than 100, that means this patient we can predict a weaning success for that patient. So for checking this frequency by tidal volume ratio, we have to allow the patient to stabilize to a normal spontaneous breathing. That patient might be on ventilator support. We will be asking the patient to breathe spontaneously, and initially for first 3 minutes we should make the patient breathe spontaneously so that the patient can get adapted to the spontaneous breathing. Then we will be measuring the expired tidal volume and the respiratory rate at which this patient is breathing spontaneously. That we will be checking for 1 minute. And we will be taking an average of the respiratory rate and the tidal volume, and we will be dividing the frequency by tidal volume. Then we will be getting the ratio. Now, how will we plan on this weaning procedure? So, we told that this patient should be asked to breathe spontaneously and all. So, we need to change the ventilator settings accordingly so that this patient can breathe spontaneously. So, if this patient is on any assist modes and all, we should change that into a spontaneous mode or any pressure support mode like that, so that patient can itself breathe and the ventilator can itself sense the patient's trigger, and accordingly we can attempt weaning. So this patient should be continued from full ventilatory support and should be placed on a spontaneous mode or to a T-tube for at least 30 minutes. And during that 30 minutes, we will be assessing the patient, how the patient is breathing, whether the patient is becoming tachypneic, any tachycardia, whether there is any hypotension, arrhythmia, sweating, and all. That all should be assessed. And we can tell that this patient has passed that weaning procedure if this patient is able to sustain a normal breathing pattern for 30 minutes. So there should be a normal breathing pattern, there should be adequate oxygen exchange, and there should be a patient should be hemodynamically stable after the test. And we will be also checking the ABG findings also. There should not be any carbon dioxide retention, any change in pH, or any oxygenation problems in the ABG also. And we will tell that the weaning procedure failed if this patient becomes agitated or patient becomes anxious while attempting weaning, and if this patient becomes drowsy, excessive sweating, and if the patient becomes tachypneic, then we'll be telling that weaning procedure has failed. So what all modes we will be putting while we are planning for a weaning? So we can either put the patient on a spontaneous mode with a T-tube or a CPAP to assess the breathing, and we will be checking how the patient breathes for 30 minutes. And while we are putting the spontaneous mode, sometimes we will be able to adjust the pressures also. So that pressure should be adjusted to a lower limit so that the patient will be getting minimum support only for spontaneous breaths. And next is the SIMV mode. SIMV mode means synchronized limited mandatory ventilation. So if the patient is not breathing, the SIMV mode will be giving the breaths. So initially we can set a respiratory rate and we can put the patient on an SIMV mode. Later on we have to reduce the respiratory rate of that SIMV mode so that intermittent mandatory ventilation will not be given by ventilator, so that the patient itself will start triggering the breath. So slowly we have to reduce the respiratory frequency set to the ventilator so that the patient will be triggered to take a breath. Other method is the pressure support ventilation. There also we will be keeping a very low pressure so that when the patient attempts breathing, the ventilator can support that breathing. And if this patient is able to reach that adequate tidal volume without any respiratory distress, we can plan on weaning this patient, extubating this patient. So why this pressure support ventilation? Why should we give some pressure? That pressure is to overcome the airflow resistance that is caused by the ventilator tubings and endotracheal tube. So that endotracheal tube, we have not extubated the patient. Patient is still on that ventilator, and there will be some resistance offered by the ventilator tube and the ventilator circuit. So that pressure will be overcome by if you are putting the patient on pressure support ventilation. And in some dragger ventilators and all, we have the automatic tube compression compensation mode that is there. If we are putting in that mode, the airflow resistance because of the endotracheal tube or the tracheostomy tube can be minimized so that we can plan on a weaning attempt can be done. So that is seen in only in some advanced ventilators. Otherwise, we can put on spontaneous mode or any SIMV or pressure support ventilation. Next is the clinical criteria and threshold related to spontaneous breathing. So, the patient, as I told, after 30 minutes, this patient should not be tachypneic. This patient should not be having any features of ventilator failure, but this patient should not be having any arrhythmias or any sweating or any tachycardia. Patient should not be in respiratory distress. And we will tell that this patient has been failed for weaning if this patient's PaO2 is less than 60 millimeters of mercury, and this patient requires if this patient requires more FiO2 to maintain oxygenation, or if the patient's saturation is falling less than 90%, or if the patient's carbon dioxide is increasing more than 50 while we are doing the spontaneous breathing trial, and if it is a COPD patient and all, if this patient's carbon dioxide is increasing, the partial pressure of carbon dioxide is increasing more than 8 millimeters of mercury from the baseline while the patient was on ventilator or before intubation. From the baseline, if the patient's carbon dioxide is increasing, that all accounts to a weaning failure. And there should be, because of that respiratory acidosis, this patient's ABG might get worsened. So if the pH falls less than 7.32 or there is a drop in baseline pH of 0.07, then that also accounts for a weaning failure. And as I told before, the rapid shallow breathing index, if the respiratory rate by tidal volume is more than 100, That means patient is tachypneic. And the patient's respiratory rate shouldn't go more than 35, and the patient's or the respiratory rate should not increase more than 50% of the baseline. These all will be considered as weaning failure. And patient should not be having any tachycardia of more than 140. Patient should not be having patient's BP should not increase more than 180 millimeters of mercury. And if this patient is already having a very high blood pressures, that blood pressure should not increase more than 20% of the baseline. And if the patient if the patient is having a normal blood pressure, and if the systolic blood pressure is falling less than 90, and if this patient is developing some arrhythmias, these all account for a failure of spontaneous breathing trial. So, before weaning, we should make sure that this patient's initial indication for intubating is no more there. So, the patient's reversal of the underlying condition should not be there, and the patient should have spontaneous inspiratory efforts. Patient should be hemodynamically stable. Patient's PO2 by FiO2 should be more than 150, or the patient's PO2 should be more than 60 with minimum FiO2 of less than 40%. And patient should not be on any sedation or paralysis while we are planning for a spontaneous breathing trial, because patient should be awake and patient should take his own breath. Then next step is we should check the rapid shallow breathing index. That should be less than 100, and this patient should be able to tolerate, or patient should be able to do a spontaneous breathing trial at least for 30 minutes to tell that this patient can be successfully weaned. What all are the signs of weaning failure? We have already discussed that patient will be tachypneic, there will be use of accessory muscles of respiration, there will be paradoxical abdominal movements, patient will go into hypoxia, patient will be anxious, then this patient might carbon dioxide retention will be there, patient will be having some sweating, delirium, agitation, dyspnea and all. So we've already discussed the indicators for weaning failure, that is the increase in carbon dioxide, decrease in pH, decrease in PO2, decrease in saturation, decrease in PO2 FiO2 ratio, change in the vitals, that means either increase in systolic blood pressure or patient going into hypotension, tachycardia, arrhythmias, and respiratory parameters like patient is not getting an adequate tidal volume of at least 5 ml per kg, or if it adult patient, if the patient is not getting a tidal volume of 250, and if the patient's respiratory frequency is going up very high, more than 30 to 35, and a rapid shallow breathing index more than 100, and if there is no minimum negative pressure of -20 that is required for inspiration, and if this patient is having a very low static compliance, and if the patient's dead space ventilation to tidal volume is more than 60%, that means patient's dead space is more. Then some other conditions can also contribute to weaning failure. That means other than the initial indication for ventilation, ventilator associated pneumonia and all, some other parameters can cause weaning failure. That is, we will be attempting a spontaneous breathing trial when this patient is already having an endotracheal tube. So this area, cross-sectional area of an endotracheal tube is very much less as compared to adult glottis. So that can increase the airflow resistance, and and the ET tube might be long, and there will be ventilator tubings and all. These all might be causing some dead space, and there will be resistance also. So we will not be getting that tidal volume which that patient is supposed to get. So that can contribute to a weaning failure. And if this patient is on a prolonged ventilatory support, this muscles, the respiratory muscles were not being used up. So this muscles will go for a disuse atrophy. So that can also affect this patient's weaning. Then other factors like electrolyte abnormalities, mainly hypokalemia, hypophosphatemia, hypomagnesemia and hypocalcemia, can also contribute to respiratory muscle weakness. Thereby, this patient will not be able to take breath spontaneously, and thereby this patient might go into a weaning failure. Now, we have not been discussed about complaints now. So, some conditions that can reduce the static complaints are this patient is having some. If this patient is having some lung collapse or ARDS or an tension pneumothorax, or this patient is having an obese, if this patient is obese and if this patient's abdomen is very much distended, these things can reduce the complaints and that can affect weaning. And if there is some secretions also that can affect, that can increase the airflow resistance and reduce the tidal volume, that can also affect the weaning. And reduce dynamic complaints like bronchospasm, any kink in the ET tube, or any airway obstructions with some foreign bodies or secretions also can affect the complaints, and this also will cause weaning failure. So make sure that this patient doesn't have all these. Once the patient has come out of this initial indication for ventilation, we will be stopping the patient's sedatives, paralytics and all, and this patient we will be explaining. Once the patient is conscious, we should explain the patient that we are planning for a spontaneous breathing trial and we should trigger the patient to take breaths. Then we will be doing a spontaneous breathing trial for 30 minutes. Then if this patient has been successfully passed that spontaneous breathing trial, then we can plan on extubating this patient. And depending on the patient's initial condition, we can extubate this patient either to an NIV or a face mask. Thank you.